Hello, everyone. Thank you for coming to the Tower Hamlets Trauma-Informed Community of Practice learning event. We're going to be hearing from Dr. Myrto Tsakopoulou today from ELFT, or East London Foundation Trust, about a project that her team have been implementing over the past while that's been using a particular tool that was developed in the northeast of England on evaluating trauma-informed approaches. And so just so everyone knows, we're recording the session, so you will be able to tune in again after the event, and I'll be sending out the slides and everything afterwards as well. I think many of the people here will have signed up for the mailing list, but I'll share the link to that after in case you haven't already, and you can stay in touch with what's going on with the community practice. We'll be having monthly sessions like this throughout the year on different topics. And I'll also include the link to previous events and upcoming ones in the email after the session. So on the topic of evaluation, I just wanted to bring everyone up to the same speed or into the same room, because I know we're coming from all sorts of different places to the topic of evaluation, and potentially also to the topic of trauma-informed approaches or care. And so people will use lots of different frameworks for evaluation and lots of different methods. One of the ones that I think is quite useful when thinking about kind of more, or there are two actually that I think are quite useful for thinking about kind of more complex evaluations where you're thinking about lots of different components to something that is being implemented. One of them is the CDC framework, so that's the pink circle that's got those different steps from engaging stakeholders to describing a program to kind of choosing that actual evaluation design, gathering the evidence, justifying conclusions about what you see, and ensuring that you are using and sharing the lessons learned. And the CDC also have 4 different standards for what makes a good evaluation. So these are things that we can think about as we're hearing from Myrto. So one of them is around utility, or how useful it is, the feasibility, so that relates to things like whether it's actually doable to conduct the evaluation, or if basically the kind of project management side of things. Propriety is just a fancy word for like ethics, and things like safety and safeguarding, and then accuracy, which is also very important and as far as using evidence. And then I've included a definition of evaluation at the top and bolded some of the key components to it. So it should be like, while there's not any one good way to do evaluation, it's not just doing a survey, let's say. And so we are looking at a structured way of assessing something that's been implemented, whether it's an activity or a policy, and determining how well it's achieving what we set out to achieve. And ideally, that should then contribute to decision-making or future planning. And there's different kinds of questions that you might ask in an evaluation. So I've kind of mentioned some of them already, and they're there. And then I've linked also to a new framework for conducting complex evaluations, or evaluations of complex interventions, which I think trauma-informed approaches are, because it's not just one thing, it's many things. I think the presentation will also relate to reflection, so I've included an example of a reflective model. This is the Gibbs reflective cycle, and it does kind of follow similar steps to an evaluation, but perhaps just using a different approach, and maybe they're appropriate in different ways. So just keeping that in mind as well. And then finally, if you're coming at this not being as familiar with trauma-informed approaches, I think Myrto will talk about this as well, but just in case. Trauma-informed approaches have kind of 4 assumptions to them. So it's about understanding how trauma affects individuals, as well as communities and everything in between, so families, organizations as well, and the impact that it has on different areas of a person's well-being or a community's well-being. It's also about recognizing that and being able to spot how that comes up in like different symptoms, but also how we work. It's about how we respond and incorporate our understanding of trauma and the impact of it into our ways of working. And then finally, it's about how we try to find different ways to avoid perpetuating or furthering trauma and avoiding re-traumatization. And then the 6 principles in the purple box are kind of ways of practically thinking about that. So you might read these and think these are just, examples of good practice, and that is probably true. So it's about emphasizing things like psychological and physical safety, trust and transparency in the way that we communicate and interact with each other, and finding different ways to share power and collaborate, and then also taking into account the different cultural, historical, and gender issues that exist in the worlds that we work in. So basically, the reason I wanted to bring that in is because it's important to think about what we're actually implementing when we go to evaluate anything, really. With that, I'm going to hand over to Dr. Myrto Tsakopoulou.
Thank you, Angela, for trying to pronounce my whole name. I really appreciate that. But yeah, Myrto is fine. Hi, everyone. It's good to be here. Let me start by sharing. Sorry if I have any, have to excuse any issues with the technical side. Can you see that? All right, great. Very good. So it's good to see a few people, familiar faces here, and some new people. Just to tell you just a little bit about, oops, what's happening? Okay, all right. So the plan for today, I will tell you a little bit about who we are as a team, a little bit about roots, a little bit about what was the process of using it, and just some general reflections. And hopefully we will have a bit of time to ask, to answer questions and have a little bit of a discussion about this. I will not go into the details of trauma-informed care. I assume that most of us here know, you probably know a bit more than I do in some areas, I imagine. And also, Angela, thank you for the brief introduction. So this is our lovely team, complex emotional needs and complex trauma. And I can see some people here already. Yes, Matthew, you're in the center of it. If it's okay for the people who are in this team to just raise your electronic hand so that, people can tell how many of us are here. And also we have, additionally to the people in this picture, we have the CAPs who are placed in, so that's clinical associates in psychology, who are based in the neighborhoods. Malaika, shout out to Stephanie and Wopin, and there may be some others, so thank you everyone. So we are a team, we are a relatively new team, and that is, I think, a benefit for doing Roots, to be honest. I think that we, we had a lot of energy to put into this. As you will see, it's something that requires a lot of commitment. So we came out of the transformation initiative in Delft, and we are here to basically help improve the care, the pathways for people with complex emotional needs who may have difficulties associated with personality disorders, and to create also new offers. So we offer different things from individual and group therapies, but also supporting teams with consultation, with reflective practice, with thinking psychologically about the needs of people with complex emotional needs. Trauma-informed care is very much part of our being and our ethos and our values. So it was also always something that we were very passionate about. So we see presentations and what people come with through a trauma lens. Working closely with our service users, with people with lived experience is very important. So our values are very much in line with trauma-informed care. So it was very important for us to think about, are we doing trauma-informed care? I'm also personally, I have also been involved with training, offering training for trauma-informed care across the trust and other services. And I guess, I don't know, I mean, this may be, you know, relevant to a lot of you, you know, that there is, I always felt that there is the theory behind trauma-informed care and a lot of things that we agree with, but then there's always the question, okay, so how do we do this? Like, how do we do it in practice? What does it mean? So, so we were looking, we're always very interested in trying to work out, you know, different ways. And it's worth mentioning that there are different tools out there. We mentioned a couple here from Oregon, and there's some work from Scotland, who have been, you know, way ahead, I think, from England to thinking and implementing trauma-informed care. We picked Roots, which was, it's a relatively new type of evaluation tool, if you like. It's UK based. It was produced within the NHS sort of ethos and environment. It's co-produced. And it seemed to have more detailed and relevant items in terms of the specific practice that we use. And also, we had a lot of discussions with other complex trauma leads. Is Patricia here, Hubers and Sam? If you are, oh, hi. Yeah. Oh, great, great to see you Sam, here.
Unfortunately, is not well today, but yeah.
You'll be representing BNL. Great, thank you. Really good to see you. And it's worth saying, yeah, Patricia, the lead there, they were involved with a Root pilot in Bedford and Luton. So we've been having a lot of discussions about this. We also had some consultation sessions with the developers of this model, Angela Kennedy and her team. And it's worth also saying that I think, Patricia, your presentation on Roots is also available. There is a recording of it, and I will circulate it to people here. You may be interested in finding out a bit more about what they did in Bedford and Luton. Yep, Patricia?
Yeah, just to add that we now have training videos available as well for the Roots. Finally, took a long time. Sorry, guys, but they're now available, and I sent them to Patricia Potter, who can share. They are only for ELFs, so they can't be shared outside, and they are not available to the public, but they're YouTube videos that can be used.
Lovely, thank you very much. So, what is Roots? We will circulate. There's, you know, you can find out a lot more about that. We can circulate the material that is, you know, we used. But the main point is that it's a reflective tool, practice-based guide to support the transformation of services and settings and becoming trauma-informed, building on the learning in the implementation framework. So it's very important to note that it's not really an outcome measures in the strict sense. And I think, Angela, you made a good point there about different ways of evaluating. So this is one of those things that just supports reflective practice, thinking with a team, are we in line with, you know, with these values, rather than having an outcome to say, okay, are we doing, like, are we failing? Are we meeting the, you know, threshold? This is much more about creating a space to reflect on our practice. You can find all the information on this website. So it can be used by individuals or teams. It's designed to provide a reflective overview of how well we are progressing towards trauma-informed care. It identifies key areas, so it has 7 domains. I'll go through them in a minute. Each of these domains has between 7 to 11 items that you can go through, and they are 55 items in total. So these are the general domains, and as you can see, they are closely linked, if not identical, to the principles, and they are very much informed by those principles, and they came out from discussions and thinking about what makes an organization or practice trauma informed. This is an example. This is of the first domain on safety. This is part of the staff form, but there is also a service user form. As you can see, these are 4 of the items of this. So when we come together, we are discussing the first part. Is this relevant to our service? Then you use the traffic light system to rate. And as we said, you can do this as a team or an individual. And then we give specific examples to justify this rating. And that's basically giving the point, the opportunity to discuss these specific parts. So the process, and that's coming from the developers, of completing routes is as important as the finished report. It is through the consensus decision making on practice points, reflecting on how well it is embedded using actual examples, and then deciding how to take it forward. That routes uses what we know about complex system changes. It builds shared awareness, shared motivation, shared goals. So basically, they are putting a lot of emphasis on the process of doing that. And as you will see, this is what we also found in our team, that it was that discussion, that opportunity to think about stuff that about those principles and actions, that was the most helpful part for us. Just to give you a little bit of the more specific, so we met for between my God, it does look like a very long time. November 22 we had our first meeting, and then in February we had the kind of last meeting, but again, it's not a last meeting because we are having review meetings, further discussions, so it's never ending, which is a good thing. We had 9 meetings during that period. We had an external facilitator, but she was elfed. Unfortunately, she couldn't make it today, Danielle. She was a complex trauma lead based in one of the other boroughs. And then again, to note, and that may be part of the discussion, is it was important and very helpful actually that she was already trauma informed, trauma aware, so she was a professional already involved with this process. So who attended? Me as the lead, and then we had the CEN clinicians, the complex trauma lead, the neighborhood CAPS, as I said, which is the clinical associates in psychology who are based in the neighborhoods. They are also facilitating the pathway of CN. And we also had an expert by experience, our lovely Mina. I don't know if she's here today, but most of you may know her. She was, she's our pride and joy. So we completed the staff part only, and that will be discussed later. So we didn't do the service user part. So these meetings were about an hour each time, and throughout that time we managed to go through the whole document framework. The results, we produced 23 action points across all the 7 domains, and the actions were allocated to specified clinicians. Again, we will have a discussion about that. And we are now in the process of having a follow-up session to review these items that we produced. Okay, so this is just to give you an idea of what the actual work that we did. So as we said earlier, you know, this is from the first domain on safety. This is item 5, which is the underlying psychosocial causes of risks are actively addressed. This is the actual item. Then through the discussion, we generated these change ideas specifically for our service, you know, so discussing psychosocial difficulties on assessment and therapy reviews. So this is to make sure that we're all having these discussions with our clients about these different, you know, specific difficulties that they have in social then offer practical support where needed. So we are actively trying to do our best to meet that need, because we think it's very much linked with, with people's presentation, distress, how they express their distress, improve collaboration with neighborhoods, multidisciplinary teams who have more resources. Okay, so this is part of one of the sort of the challenges that, again, we can discuss, but this gives you a good example where we as a small team, there's only that much we can do in terms of this area. Obviously, you know, we're part of a much wider system. Our clients should be, some of them or most of them are also under the local neighborhood teams. Those multidisciplinary teams, they have more resources, but sometimes more resources, I don't know, maybe, I don't know if there is anyone here from the neighborhoods, but they probably have different ideas. But this is just to give you the view that sometimes we may identify an area that we need to be collaborating and working alongside the wider system, but if the resources or the support is not there, is not available in the wider system, then we are also lacking in that area. Don't know if that makes sense, but this is something that kept coming up, that there is, you know, one way of resolving one issue and finding solutions within our team, but then looking at the wider, bigger picture, of course, we're very limited. So if there are no housing, there's no housing available in Tower Hamlets, and someone is homeless and they're sofa surfing and then they are distressed about it, there is, you know, very little that we can actually do about that, but we can still, you know, it's still part of our thinking. Then, yeah, review community resources. So this is, you know, information that we have in our drive. This is another item example. We take a collaborative risk management approach with service users to minimize inadvertent long-term harm to healing. So again, this is about collaboration. So we are very, you know, it's something that we want to encourage. So we were thinking, you know, this allowed us to think a little bit more about the crisis and safety plans that we have with our clients, how to do them more collaboratively. We changed a little bit the specific plan that we use. Again, we're starting thinking about how we can actually collaborate with the neighborhood teams, with the MDTs. As you probably know, every service may have their own different kind of forms and ways of assessing risk. How can we actually also speak for our clients in these discussions, advocate from their perspective in the actual, you know, safety plans and how they are implemented by other services. So a lot of thinking about that and how to collaborate more with the system. Yeah, then there's another one about our service users' opinion and voice. So again, kind of we looked at ways to improve the engagement of our service users. Okay, so what was good about Roots? So definitely good that it's very much based on the trauma-informed care principles. It's practice-based, so it's a step beyond the training workshop. So it's not just, okay, you've done your workshop, tick that box, you're now tick. This is much more about, okay, what do we need to do? What does it mean in practice? It's a tool for reflective practice, which is very good for our team. It really fits our way of working. We very much value having open discussions in the team, having different voices, thinking about how we do things. Are they working? Do they work or not work? Relevant to our services, principles and values. Item questions seemed relevant to our practice, so they are not too general or too abstract, and they can be, you know, they can be adjusted. It's flexible. We really like that because you don't have, I mean, we went through the whole list of every single item because we are perfectionists. I don't know what we are, or just didn't think this through very well. But anyway, but you can pick less items, so you can pick which are more relevant to your service, or you can add new ones if you think that something is missing that doesn't quite capture. So we like that flexibility. And it was definitely good having an external facilitator. Challenges. So staff turnover. We had a lot of staff coming and going, and that creates a bit of a, we started with a completely different team, ended with a completely, like we are now in a very completely different structure. It's a very, yeah, I mean, I think I've been, you know, maybe 2 or 3 of us have been the main, you know, people saying, but it's an issue. Who holds the team, like who makes the team? We are a blended service. Again, we are not just one team, because as I said, for, you know, the CAPs are based in different, you know, they have different, they're managed operationally by, you know, different services. Would it be easier to just have our core team? Maybe, but then we're also missing out the opportunity of thinking of the wider system. It is too long. I think that's something that has been said before. It took more than a year to do everything. You really need a very committed lead, team, facilitator. I mean, the facilitator, if they are external, they need to have this allocated time. Language and concepts. Yes, we need to have a high standard of English. So again, you know, it's not that accessible sometimes. It can be made more accessible, but it's something to consider depending on, you know, the makeup of your team. We decided to have a named clinician. I think for a few months we were trying to do everything together and come to consensus together, but that was taking a very long time, even longer. So then we decided to just allocate specific items to named clinicians. So they came up with some thoughts and ideas, and then we discussed them as a team, and we came up with some change ideas as a team. But pros and cons, but that was a, you know, a way that we found to manage that. Service user feedback part. We think it's really important, but it will be very, very hard to complete. We think it needs modification, needs to be more user-friendly. Representing diversity needs diversity rather than having one voice for speaking for all. It's very important. As I said earlier, you have the kind of the wider system issues versus the specific service. And then, yeah, consensus can be a little bit hard, because you have very different voices, which is also a good thing. But when you're, yeah, pros and cons again, you know, so how how do you decide the rating when you have such a wide range of people thinking, oh no, we're green, oh no, we're totally red, and like, yeah, how do you find the middle ground? This is from Danielle, who we're grateful to for being our facilitator. So she, additional comments is that, you know, she was there to support the team. She used a coaching style, which was very important, especially when you're a psychologist. It's kind of, I think, very tempting to just go into psychology mode and try to analyze everything that is said. So it's good to have a more structured style in a way that it's like you cover everything, you facilitate people to speak, but you're not going too much in depth if that's not helpful. And she produced a report, which is what's recommended. And then for future recommendations, she said would be, better to have a clearer time frame and maybe shorter and more frequent meetings. I'm coming to the end very soon. So the most valuable gain, it was the process, the coming together. They're right. They said it from the beginning. It was the sort of coming together and having these discussions, having dedicated space, because it's good to say, oh yeah, we're trauma informed and we are generally, but it's very different when you come together and you reflect on things. It can produce something very helpful. It makes it from this vague concept to something a little bit more tangible. And this is the the paper and where to find roots. Okay, I'm gonna breathe now. Any questions?
Thank you so much, Myrto. And yeah, take a second to breathe. While people are thinking of questions.
And also, sorry, can I also add, the people who took part in this would be massively helpful to also hear your experience. If you want to add anything, if I forgot anything, please, because there are a few of you here.
Great. Yeah, feel free to raise hands or put things in the chat if you have something that you want to ask or comment. I just wanted to say thank you for going through this process, because it does sound like it was a lot of work, and also doing kind of more reflective thinking is challenging. Just thinking through your own work and whether you're doing it the right way or the way that you intended can be quite a challenging experience. So I appreciate that you've done that as a team. While people are still thinking, I had a question about if you could share any of the other examples of change ideas from some of the other domains, like if anything kind of comes to your mind, just so people can have more examples.
I can, I can look because I can't think right now, but if anyone else from my team can help out while I'm looking, feel free.
Go ahead, Kitty.
Thank you for that. So that was really interesting. I guess one of the thoughts I'm having is I work in an MDT, a CMHT for older adults, and I'm thinking about, so it's a big team, and that sort of feels different from perhaps where you were located, maybe perhaps more explicitly kind of psychologically driven in terms of what you're offering within your service. And I guess I'm just sort of thinking out loud about how whether you've got any ideas about sort of buy-in around these sorts of processes in teams where the sort of assumptions about the usefulness of this and the importance of this aren't necessarily central, perhaps particularly in systems where there are more kind of traditional hierarchies. I mean, I suppose ironically that speaks to the principles of trauma-informed care anyway, but whether you've got any thoughts on that.
Yes, it's a very good question, and I have to say, I think it does have a lot to do with the general how much there is a buy-in from the top, if you like, having more executive and stakeholders buy-in. I feel that in Tower Hamlets we've been doing well in general. I mean, this meeting, for example, is a good example, but in Elft, specifically, I think, that there is already, there are people who support that and management. Now, but you still need, I suppose, local managers, operational leads to be more aligned. I would say, I mean, it would be good to hear from others. And I know, Patricia, you've also done a little bit of work with, with different teams and different styles about this. But maybe starting with the leads would be a good point. So where you have a short presentation or you talk to them about what this is, what trauma-informed care is. I would also make sure that this route is not seen as something scary that you need to do right, you need to tick these boxes. Again, it can be flexible, and I think that's an advantage to it. So you can maybe, if you work, if it's within your remit, to kind of have a small, like a session with the leads and say, okay, I think, maybe these points, these parts of, or this specific item, it's something that we can discuss as a team, and wouldn't be great if we can make some improvements in this area, or maybe tie it in and link it in with other projects that are happening, service evaluation, audits that are taking place, because it does cover a whole lot of areas that I feel there is a lot of crossover with other service evaluation stuff that is happening, and so it can be linked up, and then I think then it will make the buying easier. Patricia?
Yeah, hi. I thought, yeah, I totally agree with you, Myrto. That's exactly what we did in Betts and Luton, but we did it with the crisis pathway and the acute pathway teams, also not necessarily highly psychologically driven. But so what we did with the facilitation is we had the psychologist in the team, so we only did it in teams where there was a psychologist. Would become a facilitator, and that's where these training videos are quite good for, because they sort of, everybody can do routes, yeah, so it's not a scary thing, but I think the videos are there to give people confidence and to talk them through it so that people feel prepared. Plus one lead from the team. So we had all the managers of those teams trained as trainers, as facilitators as well. But yeah, the very first point was talking to the leads of the pathways and say, this is what we want to do. Everybody thought it was great. The leads will all say it's a great idea, yeah, the higher management. And then it's pointing out the people, or allocating the people that would then be given time to do this with you. And so we had one psychologist and one lead doing the facilitation of each of those route sessions. And only with a smaller group of 6 to 8 people from the team. Took half a day for that. We had like a proper away day feel with lunch provided. It seemed to really help. And then the follow-up, though, which you've done much better in Tower Hamlets, has fallen by the wayside in some of these teams. Some have had another away day follow-up with the whole teams together, and then we did another presentation and did some more of the domains with a much bigger team. But interestingly, one of the teams in some of these pathways I won't name is struggling a bit, and people have come back to me and said, can you do a bit of this stuff that you've done before with them, because it was really helpful. So even though you might not do it as a constant, because people just can't, there's all these new policies coming in left, right and center that people have to be trained up in, etc. But this is like a bit of a baseline underlying thinking about, and Roots holds it together, as Myrto said, as a bit of a structure, which you can go back to it and say, can we ask ourselves these questions again, and see where we go from that. But definitely get the buy-in from the team. So we're trying to get a specialist training post filled. We have a half-time post in Betts and Luton, but it's really hard to find somebody to come and work in that half-time post as a full-time post combined with something else, to actually dedicate time to this, because it does take time. It took us a lot of time to talk to managers, have meetings, explain what it is, get them to this training, really build relationship, and yeah, go from there. Good luck.
Great, thanks for adding that other lens and example from Beds and Luton. That's really helpful. I wonder if you could say a bit more about the kind of, I know you mentioned a bit about the challenges with the consensus approach to, or discussion approach to decision making, or agreeing your rating using the RAG system for each of the domains and components. What was the approach you took to that as far as coming to an agreement in the end?
I think that's where having an external facilitator came in really handy. I don't think we would, in some cases, I do wonder if we would, yeah, but it's good to have an external person who, again, with a very, a coaching style, a bit maybe more directive style to go for, to encourage people to make decisions, I suppose. Don't know what was everyone else's experience. I don't know. Antoine, Matthew, Karina.
Go ahead, Antoine.
I mean, it's interesting, Myrto, as you were speaking, I just look back at our evolution of the roots and realized that some of the action plan, I had forgotten that it was from the roots that we had decided from, but they have already been implemented. So that in a way say it even more on the usefulness of it. For example, we were wondering in the domain around being trauma-specific intervention, we started creating that resource pack for newcomer to our service. I think I was reading that we were trying to increase our service users' participation, and since we managed to have more contact with Eva from people participation, things so. There is definitely a few areas that have come. There is some that I'm reminding we still have, is still on our to-do list, but nevertheless, there's already some that we have implemented. And interestingly, to the point that we have already forgotten that had come from our conversation with the roots, is already part of the CEN city. So I think that's on itself really say something about the usefulness of such a tool.
Great, thank you for adding that. Matthew, do you want to share something?
Yeah, thank you. So my domain was language. I guess that focusing on that we would think about how that was very anecdotal, what kind of language gets used with clients, how we apply that, the kind of power divides and whatnot. So I'd only be anecdotal with regards to that one. So giving case examples from clinicians.
Great, thank you. I wonder if people, because I realize this is quite a specific service area, let's say, and one of the things I was wondering in the background was how might this work if you're not a trauma specific service already, or if your main kind of thing that you're trying to address isn't mental health, although people might experience poor mental health and use other services. I'm just conscious of the other people that are part of this community of practice and that are here today, and what might you give as advice, let's say, for those that want to assess how trauma informed their services are?
God, yeah, good question. Matthew, do you have the answer?
I wish I had the answer. God, if
Okay.
only it was that. Yeah, that might take a while. Hang on. Just to feedback, I have colleagues and friends in other services and whatnot. And, I think we've been really lucky here. We have some fabulous clinicians, people who really care about this. We're given the resource to provide therapies, to really work with clients in a really lovely way. It's got flexibility. And I guess one colleague fed back who's elsewhere, they're very much elsewhere. And they've kind of fed back that, this trauma-informed care 2-day course was being offered, and there's going to radically change stuff, and it's not like that here. their feedback was really like, this is expected to be a bit of a kind of be all and end all, but actually the resource to invest in, trauma focused therapies, which is so broad, isn't it? And so, and they're also kind of different in a way, and multimodal, and trying to think about what's effective. You can't put a 2-day training or things and expect enormous structural change and enormous economic, social change as well. We've all been doing trauma focused care and trauma informed care for a long time, but kind of getting to the root causes of these things, that's interesting in itself. Yeah.
Great, thank you. I can see Georgina has the hand up.
Hi, yeah. I was going to say I noticed when we were doing this as a team that actually very little of our time was spent thinking directly about the kind of trauma focused work that we do, that most of the areas and the sort of change ideas were all the sort of peripheral stuff that is so important. So it was thinking about the liaising with other teams, or the setting up appointments, or the managing risk, not just in our team kind of side of things. So I was the safety domain, and I was looking back after your question, Angela, about change ideas that had come up, and I was looking at the stuff we had was things like resources to give out on cost of living crisis, and sort of how we can communicate risk plans with other teams involved in someone's care and kind of find agreement on that stuff. So I guess my experience of it was that actually it's all that other stuff that's so important that I found helpful this put on the agenda a bit more, rather than the, what trauma work are you doing with someone in the room. So I think hopefully other services would find it helpful in that way.
I was hoping someone would think that or say that, because that is the kind of the idea with trauma-informed approaches, is that it's not specific to providing trauma-specific services. So I'm glad. Great. Antoine, did you want to add anything to that?
Yeah, I think it was exactly what you just named, a reminder that trauma-informed care doesn't mean that you're doing trauma work. It's more really reminding, realization that trauma is present and it can affect people, groups, and your service need to be aware. But that doesn't mean that your service need to treat the trauma itself. Just being aware and try to design the system so it can respond to it, and mostly not re-traumatize in the way your service is providing its care, but not treating it. So yeah, along the same line of what you just said.
Well, that sounds great. Charlotte, nice to see you.
Hi, nice to be here. Yes, I was thinking about how, thinking about an area which is not mental health specifically, but certainly is part children and family centres and early years education, which is the field I'm in. The things that you call peripheral, obviously they're not directly trauma work, but their language and safety are so important. And it would be great if there was some kind of way of having a way to think about those processes. I'm not sure that the roots tool would be the thing, but to build some kind of it is the process of embedding, isn't it? And you're absolutely right, 2 days of training is never going to make a difference. It's going to make people think for a bit and go back and kind of maybe feel a little bit frustrated that they can't then implement things. But kind of having the resource, the coaching resource, and also within the children and family centres, that's like 156 people. How you would, it would be really interesting to think more about how you could focus on building a process that works more widely, because there are a lot of people who, okay, they may not have complex emotional needs in the way that your service users have, but they have big emotional needs, and they have cost of living crisis, and they have this issue about power, that professionals have more power, which I think is another kind of area to really address. Anyway, it's just thoughts, really, kind of building on what you've said. And thank you, it's a really interesting presentation.
I think you're right, Charlotte. We're all really complicated people, aren't we? All of us, like, we've all got complex emotions, and yeah, what we're missing really is service user voice. And sometimes it's hearing some people that have the most difficult of experiences, who are most marginalized, to really understand what's going wrong. And yeah, we have missed that out in terms of our research there.
Oh, it wasn't a criticism. It was.
My own
I was just
self-judgment,
thinking
yeah.
how to be, why more widely.
Myrto, did you want to come in?
Yeah, no, that's a very good point. And as I said, I think that it does. I think I have a sense that, like, you only need maybe one or two people in a service who get it, or who have a bit of a, like, something that they are seeing in the service that they thought, oh, that would be a good way to maybe direct our thinking, our reflection, our kind of discussions in a more trauma informed way. Then it kind of, even, it doesn't, you don't even have to use the word, in a way, trauma informed. I think if you have some people who want to improve, the way that we talk to people, how safe we are, how mindful we are of the wider system, of the distress that they experience in how they present to us. I think that it's it's a good tool. There is a way of, like, for example, I'm looking at, domain 5 and empowerment. One of the questions is, staff and service users have the freedom to be creative and flexible in planning care together and are supported to be part of service change and innovation. That in itself is just one question. There's nothing here about trauma or, psychological thinking. This is a bit about coming together and thinking, okay, how can we be more free and creative to plan services, and to have innovation, and to empower people to express themselves. So yeah, so I think you can just pick elements of it. So as long as you have someone who has a buy-in, you can pick what is relevant and then run away with it.
I'm glad you mentioned that specific one, because I think that if you're new to the topic of trauma-informed approaches, you might focus a lot on the trauma itself, and actually some of the principles that are focused on empowerment and ways of collaborating and sharing power is actually the kind of like healing side of it, that you might not get to if you're very focused on, like, what happened to you, what happened to you. So yeah, I think that it's important to be kind of comprehensive in that sense. I'm aware that we're coming close to the end of the time, so I just wanted to draw people's attention to the link in the chat that I just posted, which is just a super quick evaluation form. If you can do that before you leave, that will be really helpful. It's just useful for us to know, like, how this session went, and also any ideas you might have for the future, because we are putting together the forward plan. But yeah, I welcome any final questions or comments from people here, or any final words from Myrto. All right. I have a question, hopefully, and this can be the last one. Maybe it will, it can be a reflective one if no one has a response, but I'm curious to hear what people have to say. Does anyone have an example of a previous evaluation that they've been part of where it didn't feel trauma informed, or it didn't feel like it was done in the process that aligns with the domains that Myrto was speaking about? And you don't have to talk about the whole thing. You can mention like a part of it. something to reflect upon. Great. Thank you, everyone. I will send the materials out after the meeting or after the session today. Thank you so much for coming. Thank you, Myrto and team, for all the work you've done and for the presentation today. And we'll be having these sessions at a similar time every month. So I'll send out a recurring invite for the rest of this financial year, so you can look out for those in your inbox. Great. Have a good rest of your day. Enjoy the sun. Make sure you get outside. Thank you.
Thank you.
Thanks, everyone.
Thank you.
That's great.
Bye.
Thank you.
Bye.